Thanks for the invitation. I'm going to talk about the other extreme that Graham has just been talking about, the people who start accumulating the diseases of aging, and one in particular, we're going to be talking about obesity. And certainly in the field of people in established HIV therapy, obesity and gaining weight is one of the hot topics at the moment. So the young researchers need to start pointing themselves out there if they're not going to come and look after Graham's group of patients. So these are my disclosures. I think the important thing is that this has evolved, and there's these key components between the two which are absolutely fascinating. I'm going to give you very much a bird's eye look at this because I can sink into the details in terms of the studies and things like that, but I think it's probably more useful to come out of this with an understanding of how the two fields are starting to come together, because there are key components which look very, very similar. I'm going to talk to you all about these various parts that look similar between HIV and obesity underneath these headings. And the first one is that very much like in the old days of HIV, and you guys some of you are old enough to remember when we didn't have viral loads, when we just had the CD4 count. And then as we got PCRs, we were able to measure the viral load, we were able to understand how actually, when I was at medical school, we kind of had this idea that the HIV virus came along and kind of went and hid away and then came back again and destroyed all the CD4 count cells. Now we know about the immunological tolerance and control of the virus and how the viral load interacts with the immunological system and all the rest of it. So we have a very good physiological understanding of that. We, unfortunately, are only starting to gain that with obesity and starting to understand that it's not simply a matter of just eating too much. It's much more common than that. And certainly losing weight is not a question of simply not eating as much and getting out there and exercising. And it's important, this thing I like, is that not a single country has managed to reverse its obesity epidemic, despite people having these easy answers as to what should happen. Part of the reason I've become so interested in this is a study that many of you have heard of that we led that was called ADVANCE, where we were looking at 3 different WHO-recommended regimens. One of them was efavirenz-based, one of them was dolutegravir-based, and one of them looked at using TAF. And most people in the world are on some variant of this, and 99.9% of people in the world are on some variant of these regimens. Most people are not on efavirenz anymore. And it was a very boring study, except for the weight gain thing. And I remember Simiso, who co-led the study, unfortunately we couldn't make the conference this year, said to me, these patients are all gaining weight. In fact, Simiso was very blunt. She said, no, they're all getting fat. And I was like, no, they're just turning back into South Africans, just carry on. And this is what prompted this. So this is data over 4 years. You can see this dramatic weight gain between the arms. And at the time, everyone, when this data was released, was like, oh my goodness, the drugs are obviously causing the weight gain, because you can see such big dramatic differences between the different drug regimens. But it's important to understand that it actually was a lot more complicated than that. That these new drugs, which is what the immediate response was, like dolutegravir and TAF were causing weight gain, it just became much harder to actually tease this out. But you can imagine the alarm when people saw this, because obesity crisis is going across the globe, and particularly in low and middle-income countries like ours. And you can see that little dark spot down there at the tip of southern Africa. For those of you feeling a bit smug about that, it's coming to you too, because it's steadily growing and growing. The epidemic and it's got a huge health consequence, it's got huge economic consequence, and everyone is recognizing it around the world. And it seems as you get richer, you get bigger. And this is one of the consequences. It gives you, I guess, more options to different foods, and that those foods are not necessarily the best for you. And all sorts of other complex social determinants come into play and change the environment in which you are. But one thing is consistent across the world is people are getting larger. And with it, I'm not going to labor this, but very complex overlays of health consequences. And they don't just follow. It's not necessarily that you get large and you get sick. It's actually, some people it doesn't happen. In fact, many people it doesn't. And in different population groups, it seems like different thresholds apply. I'll talk about it in a moment. But it does seem like there is this bewildering array of metabolic cancers, Alzheimer's, you name it. There's renal disease, kidney disease. These things all seem to have this complex interplay with gaining weight. You might ask, it's like, why were you ARV people staying around sitting on your hands the whole time? Why did you not notice this weight gain weirdness? Well, the reality of it is the drug companies do all these studies on essentially rich gay men and white men in the Northern Hemisphere. They don't do the studies amongst our people. And we have to keep insisting that they keep coming and doing that. The people most prone to weight gain are black women. And that's why they didn't notice it. Luckily, we had a whole lot of very smart people from Cape Town to come and fix us and to tell us what actually was going on here and to tease out the nuance of this. And Gary Martin's crew was able to look at this and start saying to us, they did a whole lot of fancy analyses, which these papers are all available to you, which seem to indicate that dolutegravir is not the culprit. And then Andy Hill did some meta-analyses and seemed to indicate that TAF is not the culprit. In fact, these other older drugs were actually mitigating weight loss. And if we hadn't had those drugs in the mix, if they also had been fat neutral or fat gain neutral, we probably would have seen an epidemic much earlier than if they weren't in the mix. So the weight gain is very complicated. It's associated with lessening the inflammation in HIV and then making people better, and then they start gaining weight. And it's also probably the environment we're in. We're in a very rapidly changing food environment. And then there may be some role for the medication. We're not 100% sure what's going on there yet. But what we do know is we should not be going back to efavirenz. There's a significant minority of people, what we call the slow metabolizers of efavirenz, who will not gain weight or their weight trajectory will be low. They're the same people who get all the CNS toxicity, they get the liver toxicity. So for those of you thinking, oh, my patient started to gain weight on dolutegravir, on efavirenz, I'm going back to efavirenz, that's a shocking idea. There's no probable role for efavirenz at the moment outside of unbelievably rare patients in tertiary centers in the current thing. And I think most of us think that dolutegravir is pretty weight neutral. It doesn't seem to have an impact on the trajectory of weight gain. There is some concerning evidence about some of the cardiovascular events associated with dolutegravir, but that's a complicated story that's slowly playing out at the moment. We do know that tenofovir seems to have a mild impact on appetite, probably like a kilogram at most a year, maybe even less, and that mitigates the weight gain trajectory there as well. And TAF seems to have no real impact. Again, there's some controversy about whether it's totally 100% proved, and there's some debate around that. And all the other drugs, there's huge debates about that. But when you go back to that graph and you show that differentiation, we're probably talking about 2 or 3 or 4 kilograms difference between the different regimens at most. So when somebody, say, for instance, in our cohorts, some of those patients have gained 30, 40 kilograms, changing regimens is not going to do much in that situation. And that's why we have to become obesity experts. The reasons for obesity are also really, really complicated. And if you talk to any one of you, I bet you, and you talk to people on the streets, it's like people just won't keep their mouths closed. They have no self-control. Skinny people say that all the time. You talk to people who have obesity, they'll tell you, we know exactly what we eat. We know exactly how much exercise we do. And there's tons of studies. If you talk to obesity experts, they say, the same way we as HIV experts, we say it's the context in which you live. That's what's driving this. And it's very important to understand that because we know that, we can throw as much as we like in terms of food changes. For people with established weight gain, established obesity, you can exercise as much as you like. You can change your diet as much as you like. In the short term, you'll lose weight. But in the medium term, you will gain weight and you'll almost certainly overshoot it. Almost everybody does that. And we have so much data now to show that when people come to me and say they just must exercise, they must just, when healthcare workers tell me that, it's actually just cruel. In fact, the data far more supportive of the fact that you're doing harm by promoting this stuff in the absence of a broader health program. If that's all you're advocating, you're actually not doing anyone a favor. We all should be eating better. We all should be exercising. We all should be active. But that's for general health. To lose weight, it's not a great way. It does mitigate weight gain, and certainly for those that are starting ARVs should be thinking about that and talking to our patients. So eating well, eating properly, being active, that will stop that trajectory that you saw earlier. So the other thing that there is they're very poor staging systems. We've got the CD4 count. I think we underestimate what an amazing marker of immunity that is. From the very beginning, as whether to start ARVs, whether to start prophylaxis, whether we can exhale, whether patients can relax a little bit about being healthy, that CD4 count staging system has been absolutely fantastic. Obesity needs a CD4 count system. For so long, they've used the BMI, and it is a shocking staging system for being unhealthy, for being big and being unhealthy. We know for black people, it's probably much higher than for Asian people. We have no real idea of where Caucasians fit in all of this. But there's a big review that came out a few months ago in the Lancet Endocrinology, trying to tease all this together, to say we need a better BMI, that we just need to get beyond using weight and height as the way that we're going to stage people for treatment. The other thing is that we've had to deal with is around the prevention people. Like in the old days, I used to fight with the prevention people. They said, no, people must just change their behavior. Tough luck if you got HIV, you go away and die. We failed you. Now we must do this. We must throw all our interventions into prevention. We're seeing the same thing in obesity. People say, we must just fix the food supply. We must stop wasting money on medicalizing the epidemic, and we must do that. And the problem is that it really is HIV in the 2000s. It's like this prevention versus treatment dynamic that's happening at the moment. And it's true that when you can lose weight, if you do have obesity, is that you get amazing therapeutic benefits in all those diseases I was showing you earlier. But the problem is the lifestyle changes, as I said to you, they just don't work. This is an NEJM review a couple of years ago, but they showed this, what I call the Punisher trials, which is give you almost a dietitian to stare over your shoulder every day as you eat boiled lettuce leaves, and then put you on the treadmill for 4 hours. All these people lost weight, but only a tiny minority kept it on. And it really doesn't work. This kind of moral approach to obesity, which is the last great stigma as far as I'm concerned, is very similar to what we had in HIV in the old days, which is just be moral, just say no to sex. That's the way we're going to cure this epidemic. And it reminds me very much about how we kind of following with this epidemic. This quote here from the head of the philosophy department at my university, which is very much about how moralistic medicine is if it feels good, it really can't be good for you. Like you shouldn't be doing that. So it's very much cryptic to the obesity field. Now, it's taken us ages to get away from HIV. And then what about the drugs? The drugs, honestly, this feels like the old days of D4T. Lots and lots of drugs, lots of weird toxicities. They're damn hard to use, and they are super expensive. It's exactly like ARVs in the old days. And if you look at this, it looks like the food pyramid, but it's the kind of obesity pyramid. You start at the bottom, you get small incremental changes as you go up, but then you start hitting these new drugs, and they get amazing. It depends which drug regimen you use, and it depends how good your doctor or your nurse is. But you can get up 20, 30% routinely weight loss on these drugs before you start needing surgery. So there's a whole continuum of usage in this. The problem is they are super, super expensive. We don't know how to use them properly. They've got side effects. We don't know what to do with that. We don't know how long you need to stay on them. You probably need to stay on them forever. But there are all these important things that are being factored in, very similar to the stuff that we had to consider in the early days of HIV. That's just a list of all the new drugs that are being under consideration. You can imagine this is a drug company's dream, if you're going to have to stay on these forever. And you can see, just look at the share prices of the major drug companies involved in the anti-obesity drugs, how well they're doing. And finally, there's stigma. And again, I don't need to tell this audience about the stigma in HIV, but people with obesity, you can watch on social media how people make fun of people who have overweight or obese. It's just incredible. It's actually acceptable. You would never see that in modern day sort of engagements, that people would be able to just poke fun. And it is something that just needs to change. And there's a whole lot of language changes and things that are very similar as we saw in the HIV world, which are being promoted there just to try and decrease the stigma. So my final slide, so how are they similar? And I'm going to have to look down because I don't have my glasses. So they're very, very complex, and they are very common. So they're going to both hit us. And because there's a Venn diagram of the two, as I said, those of you involved with HIV primary care are going to have to become obesity experts. I can't read that, but you're going to have to read it for me because my glasses not being there. So a lot of what we're dealing with is actually the fact that we need government intervention. We need governments for prevention. We're going to need them in the food supply. We're going to need a whole range of things which are actually going to be able to fundamentally stop people from gaining weight in the first place. But for people who have gained weight, we're going to have medical interventions that are there. And this is the other thing that's bizarre, is that black women, yet again, are the epicenter of both epidemics. Everybody else is also going to be affected, but we are going to have to recognize the fact that this is actually where they're going to go. So stigma and blame, I've already gone on and ranted about, so I'm not going to keep going on about that. And again, I really do feel like this is the stage where you've got antiretrovirals in front of you, but you don't know how to administer them en masse. And that's what we're dealing with in HIV, is the fact that we are absolutely at the point of having to find out how to get these drugs out to people at scale. And finally, just having to deal with the staging systems and the drugs and how we're going to get them to people is something we have to start grappling with. And we have to start grappling with them in Africa, because certainly in South Africa, we've got a big problem. The problem's coming to the region. And certainly for those of us involved in HIV primary care, that's what we're going to need to look at. Thank you very much.